Hi, everyone. My name is E. David Crawford from the University of California in San Diego, and welcome to our PET tumor board. PET imaging, especially PSMA PET, in my opinion, is one of the most significant advances in prostate cancer management in the last decade. It has created a lot of opportunities and also challenges. I have observed that in many tumor or second opinion boards, almost half of the cases now are focused around PET scanning, particularly PSMA PET. We recently published our latest RADAR 6 and 7 guidelines, which goes through in detail a lot of the indications for PET, the pitfalls and the ups and downs. We have a lot to learn, and we hope that these monthly tumor boards will broaden your knowledge in this area. I would like to thank Blue Earth Diagnostics, who recently developed and launched a PSMA PET product called rhPSMA or POSLUMA for this educational grant. We have gathered for this tumor board panel 3 international experts in this field. They have not seen these cases beforehand, and so they are as blinded as you are to what's going to happen in these cases. First panel member is Dr. Phil Koo. Phil is at MD Anderson Banner in Phoenix, Arizona. He is a nuclear medicine physician. Also, Dr. Daniel Petrolak, a medical oncologist from Yale, well known in the field of prostate cancer, is joining us. And a radiation oncologist, Dr. Paul Wynn from Harvard Brigham in Boston, Massachusetts. So, gentlemen, let's go ahead and get started. Our first case is that of a 71-year-old pulmonologist who has a rising PSA. He was diagnosed in September of 2011. He had a PSA of 6, a Gleason score of 347, and 3 of 12 cores. He was treated with IMRT. His nadir PSA was 1.1 in August of 13. He lives in the East Coast in New Jersey and also commutes back and forth and works in Palm Springs, California. So let me start out with Paul. Paul, what nadir PSA do we like to see after radiation?
Yeah, so the lower the better with nadir PSAs. With brachytherapy, sometimes you can get down all the way to less than 0.1, like you can with surgery. With external beam, IMRT, like this patient got, usually I'd like to get it down below 0.5. So 1.1 feels a little bit high to me.
Okay, so it's a red flag. You know, there's a lot of interest in these rectal spacers right now. You know, quite honestly, I can remember over the years with radiation oncologists saying, hey, we don't have much rectal toxicity, so why are we putting all these rectal spacers in?
Yeah, so there's a couple of kinds of rectal spacers out there. One is the Space OAR, another one's by Barrigel, and both of them have shown in randomized trials that they can reduce rectal toxicity. I think there is data out there that some patients do get rectal toxicity, and that when you put these spacers in, it can reduce it by a certain percentage.
Well, yeah, I know they're randomized trials, and that's sort of the key here. So probably the rectal irritation and things like that may have been sort of underestimated. Dan, you've spent a lot of time with adjuvant therapy and ADT in prostate cancer. What do you tell patients before they see the radiation oncologist about how much ADT to get?
Well, we look at the different risks, intermediate versus high risk. And generally, we would recommend for a high-risk patient about 18 months of ADT. You know, one of the contradictions about, one of the caveats about androgen deprivation therapy is that the older the patient, the less likely the chance of the recovery of testosterone. And also the baseline testosterone levels are important to the recovery. So the absolute amount of ADT, I think, is a little bit controversial because the question is, when do these patients do truly recover? But it's important to emphasize the synergy between ADT and radiation therapy. It goes back to Bola's study a number of years ago, where 3 years of ADT plus radiation showed a superior survival to radiation therapy alone. And so, of course, the duration and the proper patients are important for selection.
So, Paul, I don't think anybody uses the BOLA data much anymore. 3 years, do they? What do you tell patients? A guy like this, is this 6 months okay, or does he need radiation? Does he need ADT?
Yeah, I mean, certainly, like Dan said, Bola put ADT on the map, but now with a patient like this who has what we would call favorable intermediate risk prostate cancer, either you could give no ADT currently according to the NCCN guidelines, or if you want to give some, typically it'd be short course, like 4 to 6 months.
All right. So what happened to this guy? His follow-up was he did okay, but Paul hit the nail right on the head when he said that wasn't a good nadir PSA, and it wasn't. So his PSA slowly rose up to 4.8338 rather, and that was 2014 through 17. He had a biopsy following this. He had he was placed on finasteride and saw a little dip in his PSA, but he had a biopsy right after that in 2018 that showed that he has bilateral Gleason 4-3-7 cancer with a PSA of 3.6. We have a situation here where with the guy that has recurrence. He was offered cryotherapy. Actually, he contacted me. That's how I got to know the guy, because of our work with cryotherapy, and he got cryotherapy in New York. Do you think that's a good option, Paul, for somebody that's like him that failed to respond to radiation or recurred?
Yeah, I mean, as far as we know, if somebody's got a local recurrence after radiation, any of the local focal treatment options appear to have a similar chance of local control. They just have different side effect profiles. So whether you do focal brachytherapy or focal cryotherapy or HIFU or maybe some laser things, currently the meta-analyses, which are all retrospective, seem to suggest pretty similar outcomes. So I'm okay with that.
Seems like we don't see a lot of patients referred from rad-onc for salvage therapy. Is that are they waiting to some specific PSA level, or what's the holdup?
Well, usually I would check once the PSA hits nadir +2. So in this case, the patient had a PSA of 1.1 for their nadir. So once they hit 3.1, that would be time to get an MRI, look for a local recurrence, and then make that referral if the biopsy shows a local recurrence. So refer them for focal brachy, focal cryo, HIFU, laser, or even salvage prostatectomy for certain patients.
So Phil, this is 2018. What imaging should be done? What should have been done on this guy?
In 2018, unfortunately, we didn't have PSMA PET widely available. Otherwise, I would have definitely considered getting a PSMA PET. In 2018, we might have had, I believe, some other advanced imaging tools, perhaps Axiom or choline, though choline availability was limited. But I think in these scenarios where a patient has a rising PSA following definitive therapy, there's good evidence now that we should be a little bit more aggressive with imaging to identify either local disease or metastatic disease.
We had conventional imaging and CT and bone scan, and guess what? Didn't show anything, not surprising. Dan, is there any role for ADT in this guy at this point? Would you have gone with the cryotherapy?
Well, there is I've not seen any randomized data, but we've recently had a case that was very, very similar to this, where the patient we started ADT 3 months before we did the cryotherapy, then gave another 3 months afterwards. So certainly there isn't the same synergy, at least documentation of synergy between cryotherapy, but certainly you worry about any distal micrometastatic disease, which would be taken care of by the ADT.
Okay. So, well, what happened? So he had a nadir PSA of 0.18 about 6 months after the cryo, and he was very happy. He did have some complications, as you might expect, and we'll get to those in a second. Now he comes to see me, out here in San Diego a number of years later, 5 years later or so, and has PSA of 1.46. So what do? He was seen at MD Anderson in one of the satellite places in the Northeast. These are the exact notes copied out of the chart that he had history of radiation cystitis and hematuria in the past, cryoablation, and he had a stricture of the urethral meatus. And this is his PSA history. What do we do now? Paul?
Well, unfortunately, it looks like his PSA is coming up. Certainly, I'd be suspicious about some kind of recurrence. I'd want to do an MRI, or maybe, if Phil would weigh in, maybe some kind of PET imaging and see if there's yet another local recurrence. Although this time I'd be pretty hesitant to go in again with focal therapy unless it was very far away from the original lesion.
So Phil, what would you do in the way of imaging in this guy? So his PSA is 1.46. I mean, we have approval for PET imaging for a number of agents right now for biochemical failure, which he is, a newly diagnosed disease. So would you jump in with something?
It's interesting. Imaging in this setting where he had definitive treatment, he got cryotherapy. I think we need to sort of turn the tables and think, all right, what would we do with the imaging results, and really talk through how we might potentially manage this patient, look at his, goals of care, and sort of take it in reverse. If it is decided that we would be aggressive with his treatment, treat perhaps oligomets or whatnot, I would consider getting a PSMA PET. Pelvic MRI in this setting is interesting, and we often use it to detect the recurrence. But I think I'd like to remind the readers that PIRADS is actually not meant in that recurrent setting. But it is a good tool. That being said, we are learning more about PSMA PET to detect local recurrence and metastatic disease. And depending, again, how we would manage this patient, I would consider that as a possibility at this time.
So I think you said something very important. I'm going to ask Dan a question too now, is that if you're going to order a scan like this or something, it ought to be actionable what you're gonna do with it, not just say, oh, I got the scan and it's interesting. We'll talk a little bit about false positives and false negatives. Dan, what are your thoughts? Or you wouldn't hit this guy with any hormone therapy at this point, would you?
Well, looking at his PSA and his PSA characteristics, he's doubled from December of 2022 to July of 2023. So it's about a 7 to 8 month doubling time overall. And generally, in the past, if we had negative imaging, I would often base starting ADT on doubling time. So I would be inclined to start him on ADT. I think it would be important to do some imaging to determine whether he had, as you were saying, a distal method maybe radiated in addition to doing the ADT. So certainly this is somebody that I would start being aggressive about, because his PSA doubling time is fairly short.
Okay. Years ago, we used to use low-dose anti-androgens on these people. Judd Mao and I published a paper with flutamide alone, and have some people out 10 years. So anyway, so we got a scan on him. As you know, there's a new scan out called POSLUMA, which is RH-PSMA. And so this was done at his home base in Indian Wells, California. And as you can see, this was done just a couple of weeks ago, a week ago. So here are the findings. Phil, what do you think of that? I'll show you a film in a minute, but what do you think of this?
It says no identified uptake in or about the prostate gland or seminal vesicles, so that's good. Nothing in the abdominal, pelvic, retroperitoneal nodes, nothing in the bones. Really, not much to report that they're reporting on the PET so far.
So this is one of the first ones of these scans that were done, and sort of happy to see this, and unhappy in a way, but like Dan, I shared the concern about this. So this POSLUMA scan, RH-PSMA, is negative, and we do not see any activity around the bladder neck and the prostate or any adjacent lymph nodes. Let's just look at two other scans from patients who did have positive areas. and ask Dr. Koo to comment on those. Phil?
And this is not the patient that we just talked about. So looking at the first image on the screen left, you see very focal and heterogeneous activity in that pelvis, which I presume is the prostate gland. So something like that would be concerning for recurrence, and I'd be curious to see, if we had an MRI there. The image on the right, I think, two areas that you see that have low-level activity might just be the ureters, but we'd want to trace it and make sure they follow the track of the ureter. And there's another focus of activity more anteriorly, which I think we'd want to interrogate that further and see perhaps if that's a lymph node or not.
So the scans are helpful determining direction. I think we're going to see more like this with the positive scans. And I've got and I don't know about anyone else, but we have an intense interest in two areas: radiation failures and salvage cryo and surgery and things like that, but also targeted focal therapy. I think about targeted focal therapy is it's all about your target. People call it focal therapy. If you don't know where your target is, then you're going to have a failure. There's lots of energy ways to get rid of prostate cancer: cryotherapy, lasers, HIFU, electroporation. You can inject alcohol into it and get rid of it, but it's all about the target. And I think there's a value for these scans and looking what's in the prostate and helping you determine where your target is. So, with that, again, thank you all, and we will see you for the next case. Our recommendations following the negative post-luma scan is to follow the PSA about every 4 months, looking for changes in the doubling time. Consider ADT or consider a clinical trial.